My name is Rachael Jasperson. I wear many hats in the community as well, as these individuals do. I am a clinician who operates in private practice, and so I see individuals on a regular basis. I teach at the College of Social Work. I teach social work courses for the master's students there. And my primary role is as the Zero Suicide Initiative Manager for the University of Utah Health. And the Zero Suicide Initiative is an initiative that was adopted by University of Utah Health and is adopted by many systems across the globe. It's really a focus on creating a culture in which talking about suicide and asking about suicide and supporting individuals who are struggling is part of what we do. So it's about educating people, it's about ensuring that people know the resources that are available to them, and creating system-wide changes that incorporate suicide prevention as part of what we do on a regular basis. So thank you so much, everyone, for attending today. Suicide prevention is an extremely important topic, obviously very near and dear to our hearts. And I imagine most of you who are attending this today also have a special interest. And so I will go through a couple of questions and we'll discuss these very conversationally and try and get a good sort of well-rounded perspective from the panel. And if you have any questions that come up during this discussion, please put them in the chat. I do have my computer in front of me, and so those questions will be conveyed to me, and I will do my best to get to them. There may be more than we can get to, but I will do my best. And we'll go ahead and begin. So the first question that I have really looks at what can be done in general, overall, to engage in suicide prevention efforts. And so the question really is, what are some simple steps that each person can take towards supporting suicide prevention efforts? And so, Michael, I'd like to start with you on that, if you don't mind.
Yeah, I think the first thing is don't overthink it. Suicide prevention is about engagement. It's about connection. I think people, might say, I'm really worried about my friend Bill or Sally, and let that go. And say, well, I'll check with them next week. But trust your gut, engage with them, call them, ask them, do you want to go for a walk? And on that walk, ask them how they're doing. And if you're worried, don't be afraid to ask the question, are you thinking about suicide? Are you thinking about ending your own life? Those are just some really basic tools. And then reassuring them if the answer is yes, that you'll be there with them.
Yeah,
okay,
also
I'll just go back and forth.
True. I hear a lot of people say to me, after they've either lost someone to suicide or have had some sort of experience with suicide in their life, if I had known what to look for, if I had known sort of what those signs were. And when I do a lot of trainings on suicide prevention, and I spend a lot of time saying ask, right? It's push past your discomfort and ask. Nothing bad can come from that. But I also have to sort of take a step back and go, well, you don't just walk up to people, right? And be like, hi, how you doing? Are you suicidal, right?
Right.
So is there, what are the things that sort of trigger that spidey sense, right? Or that feeling that you may have. And what we call those warning signs. And there's a lot of different warning signs, and warning signs aren't an indication that somebody is going to attempt suicide, right? They're an indication that somebody may be entering a suicidal crisis, or maybe in that realm. And it warrants some discussion. It warrants some asking. If somebody's talking about wanting to die, if somebody is giving away possessions, is acting different, unusual. And so when you see those things, Michael, what would you say, how would I ask somebody who may be struggling, or who I see demonstrating some of these warning signs?
Yeah, well, my first bit of advice is to practice. These are not words that come out of our mouth naturally, and so go to the bathroom and stand in front of the mirror and ask the question, are you thinking about ending your own life, or are you suicidal, to yourself? just getting your mouth to form those words sometimes is the first biggest hurdle.
Yeah.
And then you're ready to ask that question. But then, making sure you don't have to be a practitioner or a mental health professional to know what to do next, but you can be reassuring and don't, jump 3 steps backwards if the answer is yes. Be reassuring. Say, I'm here with you. If it's appropriate, I love you, and we're going to see this through together.
Yeah, I have this story I often tell. It's real brief, and it may sound familiar to some of you. I have a friend who's very active in the suicide prevention community, and him and his husband were out for a walk one night, and his husband turns to him and says, "Are you suicidal?" And he was like, "What? No. Why would you ask that?" And his husband just says to him, "Oh, I was just practicing." And then, they had a laugh, they had a giggle, and then they were sort of able to talk about that. And I love sharing that story during trainings, which I share all the time, because people can kind of go, "Oh yeah, like that's a good opportunity," and how you can then even use a little bit of humor to sort of take that edge off. But just how, like you were saying, having the words come out of your mouth sometimes it can be so awkward. And to be able to do it in a way that is you're with somebody comfortable and can be a comfortable situation.
Yeah. Suicide's just so stigmatized, and it has been, for so long, and there's just a lot of shame around that. So even sometimes saying that word feels a little bit uncomfortable. Yeah,
and a lot of times when things are uncomfortable, we think that we're not equipped to deal with them. And we avoid them naturally, right? People avoid things that are uncomfortable. That's very natural. And so pushing sort of past that discomfort and knowing that no harm can come from you asking. You're not going to put that idea in someone's head. That's not how it works. You're not going to make things worse. All you're going to do is communicate that somebody cares, and I care, and I want to be here, and I want to hear.
Yeah. The other thing I think that's a really practical step, because we all are doers and helpers, we want to engage, and sometimes it feels like, okay, I asked the question, now I want to do something else. Well, the next thing is to maybe seek out professional help if the answer is yes. Sometimes that even means going to an emergency room, but you can call 988 even as a bystander and get advice on, okay, this is what's happened, here's the situation, what do I do next? Yeah. And then the other thing I would add is make the environment safe. If there's access to firearms, maybe the best thing to do is have somebody hold those firearms outside of the home, or maybe lock up that Costco-sized bottle of acetaminophen. Yeah. Those kinds of really practical steps that just make the home safe. Yeah. Just like we have seatbelts in our car to make them safe.
Yeah, great advice, and so incredibly true. I think a lot of times we forget about safety, right? We spend so much time focused on why people attempt suicide, that realizing that the how really is absolutely critical. Yeah. So, all right. And regarding those resources, I believe that HMHI will have those resources available to anybody that is on this demonstration today. So, okay. The next question I have is for Brooks and Hilary. There's this assumption that suicidality is often tied to mental illness, to individuals who are struggling with mental illness, particularly depression. What can you tell us about that assumption? And is it true? Is that something that we should be looking for?
Well, I can start with this just from the research perspective. Yeah. It's definitely the case that this was my assumption for a long time, and is the assumption of many of even the researchers that I work with. And it is the case that now we have a couple of really large studies. There's a big research study done by the CDC, and then our own data that is this huge study in the state of Utah, where we can see that over half of the individuals who die by suicide, who even die by suicide, have no evidence of a diagnosis of mental illness. And this is really interesting to us. Certainly a lot of people who struggle with suicide do have diagnoses and have had them maybe for a long time, but there are a lot of individuals out there who don't have these diagnoses. And then what does that mean? Are these individuals who don't have good access to care? Are they actually struggling but then don't get the diagnosis for one reason or another? And some of our research suggests that that's actually not the case either, that some of these folks who have died by suicide really aren't mentally ill, that there's something else happening, possibly extreme impulsivity, maybe aspects of social inability to get that, that sort of social network around you. We're not sure exactly what that means, and that's actually one thing that I think our research study is really going to help with, is for those folks who have been suicidal, okay, they're kind of on our radar and we know they're at risk and we know we need to give them some care. For those folks who just die out of the blue, it really might not be the case that they're depressed. We need to understand better what is happening with these individuals, and we're hoping that some of our research can help us with that. And certainly, I'm sure from a clinical perspective, you can see this all the time.
We really can. I mean, I think, we start with this premise, and for those that are in the clinical realm and they're thinking about diagnosing mental illness, one of the first things that we learn is how within the diagnosis of depression, one of the symptoms is suicidality. And so oftentimes that's actually our first introduction to this idea of suicidality from the healthcare system. And so we kind of are almost imprinted with this idea that depression equals suicidality and vice versa. And in reality, it's more that this idea that suicidality is really related to distress. And depression, of course, is a major risk factor. It's a major way in which someone can have significant distress, but it's not the only way. And I think that's part of our efforts, and really supported by Hilary's work, that's really highlighting that it's not just that when you don't have a mental health diagnosis, it was a missed opportunity to actually diagnose someone. There are other things that we need to be considering that can add to that distress and lead to that suicidality. The ACEs study, which I'm sure many folks that are watching this are at least somewhat familiar with, really highlighted this idea that adverse childhood experiences has a cumulative effect. And when you have multiple different types of adverse childhood experiences, you're at risk for a whole slew of adult health outcomes, both physical health and mental health outcomes. And when you looked at that original study, if you had 4 or more adverse childhood experiences, before you turned 18, you were 30 times more likely to have had a suicide attempt than someone who had 0 adverse childhood experiences. So when we talk about kind of that lived experience, and these are traumas, child abuse, physical abuse, sexual abuse, emotional abuse, but they're not just traumas. They're also, difficulties in the household, loss of connection with caregivers, caregivers being incarcerated. I mean, these are a whole slew of both traumas and adversities that when you have this cumulative impact, it's almost like you're priming so that when future challenges happen in adulthood, like they happen to all of us, there is this increased priming to essentially kind of flip over into the distress that could lead to suicidality. And I think especially from the depression standpoint, there was a recent study a couple of years ago that highlighted that in adolescence that they had tracked and then followed into young adulthood. And they looked at suicide attempts in young adulthood, that even when you controlled for depression as one of those pathways that could lead to increased suicidality, having 3 or more ACEs that were documented in this longitudinal study, that increased your risk threefold, 3 times more likely to have had a suicide attempt, even when controlling for depression and other mental health concerns. So there's that potency and understanding around, if we're able to start with the lived experience of an individual, we can then figure out what the right next steps are. And if we're a lay person, just like Michael was talking about, there are things we can do to be with that person and help support them. And if we're clinical, if we have that role, it's really about figuring out, well, what is the pathway that's most amenable to responding to that individual? And so kind of making sure that we're not going in and saying, well, they're suicidal, so therefore they must be depressed, and I'm going to do a depression treatment. That might be the case in certain individuals, but it's really important that we kind of broaden our differential lens initially, and then once we actually have the evidence to support, okay, this is the right pathway that's leading to this distress, then we want to target our treatment plans to be appropriate to that.
Yeah, I just wanted to add one more little piece of data from our large study, which is we can see we have about 10,000 individuals who die by suicide where we have electronic health records from about the last 2 decades. And you would assume that the most common co-occurring diagnosis for somebody who died by suicide would be depression, but it's not. So about 40% of our cases do have a diagnosis that's in the depression realm, at least one. But the most common is actually some diagnosis that has to do with a condition that is related to chronic pain. So if you think about the overlap there, and those may be complicated, that's really fascinating. And also the degree to which individuals who are providers just in the physical health arena need to be aware of these risk factors that are associated with chronic physical health conditions that can really lead to hopelessness and potentially some depression, but it really may be kind of on a different level from what a mental health provider might view as being depression. It may more be sort of hopelessness and, a feeling trapped, that kind of thing. And I have talked to people who are physical therapists who are like, oh yeah, I get this, and this is really on our radar. There are also sort of chronic health conditions such as asthma or cardiac conditions that have some elevation in our data, and we really want to make sure we get this information out there, because when you're thinking about risk signs, they're not always about anxiety or depression. They may be about this kind of more aspect of hopelessness that has to do with physical conditions.
It really gets to the point of, if we're in a system where we have the opportunity to be screening individuals who are at risk, we want to be screening for suicide rather than screening for proxies that might lead to suicide. And that is just a very different thing. So, the Prevention Task Force just came out with a new recommendation about screening for anxiety in individuals under 65. Many of our healthcare systems are already screening for depression. Yeah. We need to make sure that if we're great to screen for depression, great to screen for anxiety, but screening for suicide is different. And in healthcare systems, if you're just using the PHQ-2, you healthcare folks know what I'm talking about, that is not suicide screening. No. It really isn't. And so, if we want to tackle this head on, it's making sure, okay, yes, great, lots of great things to screen for, but if we're going to be committed to zero suicide and really kind of catching folks upstream, we want to be thinking about how do we best structure our system so we're actively screening for suicide itself.
Yeah, and along those lines too, for treatment, right? We do a pretty good job, I would say, of treating depression and substance use issues and anxiety, but we don't do a great job at treating suicide ideation, which is a way of thinking. It's a way of perceiving a way to cope, right? And so, having for mental health providers, having specialized training like CAMS care and things like that really sort of target suicide ideation is critical, because their suicide ideation may not be directly tied to some depression that they're feeling. It may be. It very likely is a bigger thing. I love what you said about the adverse life events. Like that's something to think about, and it's also something to recognize that if you know somebody who has experienced a lot of those and is then maybe going through a major situational problem, like they lost their job, or they're going through a divorce, or the death of a loved one, or the anniversary of the death of a loved one. Things like that can really sort of bring forth those feelings and emotions and thoughts. I'll have to sort of keep that in mind.
Yeah, I just wanted to bring up one more thing, which is like during COVID, we've all been so isolated, and this is, I think, enhancing some of these aspects, and then making it even more important to reach out to people. Even the loss of a pet, right? So this might have been your only companion over the last few years, especially maybe for older individuals. So making sure we're really reaching out to people, this is so important.
Yeah, during COVID, I feel like as a society we did a good job at coming together, right? Even though we were physically isolated, there were a lot of messages of hope and collectivity. And now that COVID is sort of not as central in our lives as it once was, we're going back to normal, right? And as we go back to normal, that isolation, that social isolation may start to resurface. So paying attention to things like that. Yeah.
Going into a new normal. It's
Going
not
into
just going
yeah.
back to normal. We're going
You're
into a
right.
new normal that still has a lot of features of isolation.
Yeah.
It's
Yeah.
just before we started the panel said this is the first time that I've seen most of the folks here
Yeah.
not on a screen.
I
And
know.
So this is
It's so crazy, and we're on a screen
yeah.
like 3 or 4 times a week together, and then
Right.
but in person, it's like it's so true. All right, thanks, guys. So moving along, looking at suicide sort of from a developmental perspective, how does suicide risk? How does that change over different phases of life, from adolescents to older adults? Does it always look the same? If not, what to look for?
Yeah, so I think from a research perspective, we know that what we're looking at is so heterogeneous that we think about trying to understand risk from the standpoint of there are probably underlying biological risks that make some people more vulnerable to certain external stressors like the ACEs, right? But that is really different across the lifespan, and even within particular age cohorts probably have a lot of differences. So, I mean, that's kind of just broad strokes, 20,000-foot research perspective. I know that Brooksy did a study that really looked at this issue in detail in youth, and maybe you want to describe that a little bit because that was really fascinating.
No, I think our youth study, so we did a study on individuals who died by suicide here in Utah over a decade time span. And the developmental piece really jumped out in that study. And it also spoke to the reason why we do need to be looking developmentally when thinking about suicide, because if we're trying to group a population together and say, I'm interested in individuals who have died by suicide who are under the age of 25, which is kind of where we started. The vast majority of those individuals were in that 18 to 25-year-old age range. And so the individuals who were teenagers when they died by suicide were actually, they kind of got swallowed up in the larger grouping. And if we hadn't divvied them up developmentally, we would have missed some really important key features. We saw that those who were under 18 had different means of dying by suicide than those older individuals. There was less firearm, and there was more in the way of things like asphyxia, hanging, which we knew was an issue with the older individuals as well, but not to the same degree. And we saw differences in kind of the risk of overdose. I mean, we know that in those adolescents, we see so many kind of struggling families where they come into the emergency department, and the history is often an overdose. And so we kind of have that preconceived notion, well, that must be how teenagers die by suicide, but that's not true. In fact, in our population, it was less than 10% of those who were dying by suicide in the teenage group were dying from overdose. So, I mean, still a critical thing to be thinking about, as Michael was talking about, how do we ensure that the homes are safe, but really highlighting how we really need to be focusing on things like firearms and really line of sight when it comes to these things around hanging and suffocation. And then, really highlighting the point when it comes to even diagnoses. You mentioned the 40+% in our larger study had a diagnosed mental health concern in the overall population. In our younger individuals, it was 30%. So less than a third. We could find evidence of an active diagnosis and treatment of a mental health concern. So I think, that proximity to ACEs and childhood trauma is probably heightened in that population. And so, again, not to kind of keep saying the same thing over and over again, but we really need to be focusing on looking for youth who may be suicidal and then working backwards and figuring out what's driving that versus youth who are, have a mental health concern and then just focusing all of our suicide prevention efforts on that. So that's just kind of one example about how kind of the developmental context is really key. I don't know, Michael, would you want to kind of talk a little bit more about kind of the other side of the developmental spectrum?
Yeah, I think you just mentioned this universal screening recommendation for anxiety for people under the age of 65, and I applauded that recommendation, but was really disappointed that we're not including that for people over 65, as if they don't suffer from anxiety. And older people, we think, they've lived their life and they've endured all of these stressors, things like that, and why would they ever want to end their life in their golden years? And the truth is that suicide affects everybody from 0 to 100, and I have evidence of that. And so we need to be figuring out ways to screen and in our clinical settings older people for suicide. We're not very good at that, and we often don't think of it. But we have to do that. And the reasons for why somebody might want to end their life in 65 plus years change from the reasons that Brooks was saying earlier about a breakup probably isn't going to impact a 65 plus year old like it would a teenager, for example. But the loss of a pet is a big one for older folks that are staying around to take care of that pet, and then because of chronic pain or something else, they just don't want to go on living. So we need to pay closer attention to that age group as well.
Yeah, in our research study, really the largest cohort of individuals who have died by suicide is men over the age of 60. So, we really focus on the youth because that is so tragic, and the loss of life is just stunning. But it is definitely true that if we're thinking about true zero suicide, we need to address this large group as well. And we also need to think about women. So women are far less likely to die by suicide, but they're more likely to attempt. And we need to understand what's going on with that. And there are individual groups, for example, if we think about peri-postpartum suicide, oh my gosh, this is truly tragic, and it's very understudied, and so we kind of always assume that having a child is incredibly protective, but for some people it's not. And then understanding what is going on there, it might for some people be peri-postpartum depression, but maybe not for everyone. And those sort of missed opportunities to understand truly what's leading to those thoughts. Again, we should be screening for suicide and not just focusing on, okay, there's peri-postpartum depression here. We need to actually look at people who are considering this and getting to the bottom of it. So.
If I could we often talk about suicide death, who dies by suicide.
Yeah.
And I think in doing that, certainly that is a tragedy, defining tragedy of a family's lifetime. But suicide attempts also have just massive impacts on individuals and families and communities, and we ought not sweep those events under the rug and say, well, they didn't die, therefore, we can move on with our lives, because that's anything but true for the people who are living that, especially family members who are living with somebody who's chronically suicidal, or the person who's chronically suicidal themselves.
And I think one of the biggest predictors, right, of somebody dying by suicide is a previous attempt. Right. And there's something about to be said about sort of taking a step over a line, that this sort of firm line that we've all drawn, right, when it comes to life and death, and you've taken a step over. So is it that hard to take that step again? And sometimes people will say to me, well, what about those people who are just always claiming that they're suicidal, right? Or they use it as manipulation. They use it to get the boyfriend not to break up with them. Or there's somebody who engages in self-harming behavior, so they cut on themselves a lot. And my response to that is often, are those normal and what you would consider healthy coping mechanisms? Is it healthy to use suicide threat as a way of holding on to something? Is it healthy to cut on yourself in order to relieve distress? And if the answer to that is no, then my response is the same, and that's don't dismiss it. Because if somebody can take that step, if somebody goes there, even if they go there all the time, you never know. You never know if this is the intervention or if this is the time that they may take it that one step further.
Can I add to that a little bit, just from the
Yeah.
healthcare perspective? I think often the elephant in the room is, the secondary, the vicarious trauma, the secondary traumatic stress of working with individuals who are at risk for suicide, having had a client, a patient, someone that you're working with professionally who died by suicide. And so I think that there is a natural and frankly understandable tendency then in working with individuals who are it feels like they're using suicidality as a manipulation tool, as a means to an end. We still struggle as a healthcare system in helping many of those folks get better. And I think it's understandable and natural for caregivers, when burdened with so many things, with healthcare providers, when burdened with so many things, to start to rationalize and think about, well, they're just, it's just them being them, or that's their kind of game that they play, rather than doing the work of, well, trying to understand what that distress is that's leading to it, which might not seem like appropriate distress to lead to suicidality to us, but for that person right then and there is enough of an issue to lead to the distress to make them suicidal. And I think that's where, if we had a magic wand and we just knew how to do this in healthcare, I think it would not be hard to convince people to be with those individuals with chronic suicidality and engage with them and help them, because they would see that that immediate gratification of I've helped them get better, and now I go on to the next person. And recognizing that there's a population out there that really is struggling, that is very high risk of suicide death, but is incredibly high risk for ongoing suicidality, that has an impact on us as healthcare providers. And we need to be open and honest with how working with that population has its challenges, and what do we need to advocate for within our healthcare systems, within our leadership, within our structures, to actually give us the tools we need to actually go out there and do it every day, because it is hard work. And I think if we don't voice that, we're left with resulting to those frankly unhelpful coping strategies that healthcare providers use of rationalizing that behavior and then almost pushing those folks to the side.
Yeah, I mean, it's not even just the healthcare providers, but it's all of us, right? So we all have friends, family members who have struggled in the past with this. And it is incredibly easy to try to avoid it, and also even to rationalize at the level of, this is a choice that this person is making, and it's and that's what is really underlying all this stigma that is still with us. And one of the things that I am hoping that our research study starts to do is to show us that this is really an underlying biological thing. We need to reset this as a medical condition. If somebody were at risk for diabetes, we would totally have them in care. And we wouldn't blame them for, maybe some of their weird eating habits, right? If somebody is at risk for suicidality and they are not as good at coping with stress, we need to not say, all of these behaviors that they're engaging in is a choice. It's not. It is something that is really driven by a lot of these risk factors that we need to get our minds around, and then it's easier for us to engage with them and to help support them and to help care for them.
When you see no other way, how much choice is there?
Yeah.
And I think that a lot of that is the case. And so with the final question that I have, the final prepared question, and then we'll move on to answering some of the questions from the attendees, is very post-vention focused. And the question really is, how do I support somebody who has attempted suicide or a caregiver who has lost someone to suicide? And I want to start with this one, because my very first reaction to this is listen, is just is listen. And listening isn't always as simple as, just looking at somebody. Listening is an active engagement. It is asking questions for further information. It is paraphrasing things back. It is demonstrating empathy. When we talk to suicide attempt survivors, which has been a driving force in the Zero Suicide Initiative, is really the attempt survivors, and we say, what could we have done differently? How could we have supported you through this? Most of the time, they say, I just needed somebody to hear me. I needed somebody to see me. I had all of these thoughts going on in my head, and I couldn't get them out. I couldn't get them out because I was embarrassed, or there was shame or guilt sort of wrapped up in a lot of those emotions. And it was hard for me to go to my mother or to my spouse and say, I don't think I can do this anymore. I'm thinking about killing myself. That's a hard thing to do. And so if you can ask somebody and open that up and then listen to hear them, don't listen to fix them. Listen to hear them. I think, in my opinion, that is one of the most critical things that you could possibly do. And sometimes listening is enough. Sometimes there isn't this huge to-do that has to happen, but that being present and listening and validating what they're going through and demonstrating empathy can really make a huge difference.
You use the word fix, and I think that that's a really important thing to distinguish what can be changed and what cannot be changed. The pain cannot. It's not yours to take away. It's not yours even to lessen. It's just yours to be present with.
That's powerful.
But things that you can fix are the dirty dishes on the sink, the maybe the cleaning their house, something like that. Of course, with their permission, but maybe insert yourself in some really practical ways. One of my favorite authors, Parker Palmer, wrote, and he writes beautifully about the experience of depression, is that the most beautiful thing anybody ever did for him was rub his feet. And for 10 minutes a week, something. And so I think that just that being present. But also, I hear all the time from people who've lost somebody to suicide. That's my role at the medical examiner's office, that they kind of were shunned by their church community. They were, their neighbors didn't come over and offer condolences. They didn't get cards. We send out sympathy cards after somebody dies by suicide. And sometimes I'm like, are people even getting these? Are they opening these? And I hear more than once a year, sometimes more than once a month, that that's the only card they got. And that is so incredibly isolating. And we just talked about risk factors for suicide, isolation being one of them. These are people who are living through the tragedy of their lifetime. So if you would have taken a casserole to them, if their son or daughter or spouse or father had died by suicide or died by cancer, then you better take a casserole over if their son or daughter died by suicide too.
Thank you.
And actually, just to kind of translate what you're talking about, which I think is so critical, both on the practical aspect and the listening piece, into the kind of the healthcare, or really any systems that are serving individuals who have lost a loved one to suicide. It's starting with that, again, piece of, I can't understand how this has impacted you just by looking at you. I do need to listen. And when we think about kind of the potential for there being significant grief that can be functionally impairment, but completely understandable, and it's part of their lived experience, or having a traumatic component to either having seen something related to the suicide or knowing about what's happened to their loved one, can result in traumatic stress symptoms. Again, not pathologizing, but rather just understanding how that this loss is impacting this individual. And it doesn't have to be either one of those two kind of ready-made molds. It can be something that is unique and important and meaningful and challenging to that individual. And they're the only ones that can educate us as to what that is, so that if we happen to be in a position of providing care, we can then work with that child, that adolescent, that adult, and ideally some of their family social supports to come up with plans to address the things that are most difficult. But it really, it's what you said, Rachel, in terms of listening. I would almost just want to say that that is what we need to be doing in healthcare and other systems that serve families, but on steroids.
Yeah.
Rather than kind of assuming and then moving forward with something that I think would be the best. It's really, how do we pull out from that individual, what is it that they're going through, and help and allow them the space to inform us how we can be most helpful.
You know, doctors are good at something, and that's referring people to other doctors. And so the University of Utah, in my opinion, is one of the best centers for grief and helping people learn some valuable skills on how to carry this new, deep sadness. And that's the Caring Connections program at the College of Nursing here at the University of Utah. I tell folks all the time, I would send my mother, my grandmother, and everybody I know there when they need it.
I'm so happy you did that plug because I was opening my mouth to do it. And the fact that two of us are like Caring Connections, I think speaks very highly of the program. It's for all types of grief as well, grief from suicide loss, but also other complicated griefs that people may be experiencing. It's free, and a lot of times what people don't realize is that not everybody who is struggling needs a therapist. You know, as you said, we're really good at referring, right? And so especially in healthcare, we're like, oh, behavioral health issue, let's get you into a therapist, let's get you into a psychiatrist. And I'm not saying that that is not necessarily what is needed at times, but sometimes support groups are so much more effective because it makes people realize, it helps people to realize, I should say, that they're not alone, and to see how other people are coping and maybe what they're doing well. And to be able to share that with other people and to be able to connect is so incredibly powerful. And Caring Connections offers that. So, oh, my monitor went to sleep. So I want to move on to a couple of questions that have come in through the chat. And this one is so near and dear to my heart. And so I really I want to put this out there for you guys. How would you approach somebody in the LGBTQ or trans community that you might be worried about, especially if their surroundings, such as their family and peers, might not be accepting of their lifestyle? What are your recommendations on how to handle that?
Well, as a gay man, I'll start. Again, listen, and then go back to. Also, maybe don't call it my lifestyle. I like to think of my lifestyle as being like mid-century modern meets outdoors, but my husband would say it's more kitschy than that. So it's my sexual orientation, and it means that I married a man. I'm gonna date myself a little bit. I went to high school in a time when gay-straight alliances weren't a thing. They are now. If you know that your school has one, that's something, if you're talking about somebody who's younger, try to get them connected to other queer spaces, not just queer people, but queer spaces, because, you know, oh, my friend's gay, and so we can like introduce you to, but you know, I'm not into video games, and a lot of gay people are, just like a lot of straight people are. So if we can get into queer spaces, it creates normalization. It introduces us to other people who we can be friends with, who we do have things. We like to hike, we like to do whatever, whatever together, and have those affinity groups just like you do in any other space. But I know that there are some clinical things that can happen there too, and I'll turn it over.
I mean, so I'm a cisgender heterosexual male. I use he, him pronouns. And I have had the fortune of working with a number of adolescents, particularly of the LGBTQ community. And I think first and foremost, I mean, when we talk about why we need to have safe spaces and why we need to be open and, you know, understanding someone's gender identity and sexual orientation is a part of healthcare. It is a part of education. It is a part of child welfare. It's a part of all of our systems that we have in place to help support the normal growth and development of our children as they go into adolescence and young adulthood and as they become productive members of society. And if the setting is not a safe space to know these important aspects of the families that we're working with, of the youth that we're working with, of the young adults, of the older adults that we're working with, we can't even have the conversation about how do we understand in someone who's suicidal, how that may or may not be related at all to their suicidality, and we can't even have the conversation about how we can invite or encourage or link up to spaces that could be better suited for that individual, or could be, provide connections, remove some of the isolation that person might be feeling. So they go hand in hand. Having, stickers, having badges, having pins, being comfortable asking the question in the first place. It sounds so basic, but it's so critical, because otherwise you're only working with kind of knowledge about half the deck, and you're just essentially trying to problem solve this, what sounds like a really bad situation. This person's suicidal, and I'm trying to help them, but I don't understand their lived experience, and therefore I really can't do this in partnership with them. And so I think, to me, when we talk about kind of, the LGBTQ, this is a critical part of healthcare and of suicide prevention. If you are part of the LGBTQ community, it does not mean that you're suicidal, right? I mean, but if you are suicidal and you are part of that community, our healthcare systems need to be responding in ways that are going to actually, result in things that work for you, and that just needs to be part of like our culture. Really.
Yeah, think of your crisis as I don't belong here.
Yeah.
Let's go from there.
Yeah. Awesome. Another question, we have lots of them, so as an organizational leader, how can we help allow these conversations to happen without stigma in our organizations? And this is a really important question. We're doing that now, right? It's part of what we're doing. And I always like to use sort of little stories to sort of help drive home a point. And in the past, we've had people who have reached out to us for the Zero Suicide program and say, I believe in suicide prevention. I really, really do, but I struggle with how often you use the word suicide, because it's an uncomfortable word. It creates uncomfortable feelings, and my heart goes out to them, because I understand how difficult it can be to hear the word suicide over and over and over again, especially if it's something that has really, really impacted your life. The problem is that if we avoid saying it, we feed stigma, and that's a problem. And so it can be really uncomfortable as a leader to talk about suicide with your employees or with your staff. And what I often say when things are uncomfortable is to speak to it. We're going to talk about suicide, and that may be uncomfortable. It may be uncomfortable for me. It may be uncomfortable for you, but we're going to talk about it because it matters. And then you're communicating organizational values on some level, and you're recognizing that there's going to be discomfort, and that's normal. That's a normal reaction when you're talking about something that may be life and death. And so I think that that is primarily my recommendation, is to talk about it, bring it up, acknowledge that it might be uncomfortable, but move past that and don't avoid saying the word suicide.
It's interesting, because I think, I'm not like an organizational leader, right? But I do lead a lot of, a big research group. And I found that one of the things that is very helpful is to bring your own experience to the table first. Like, to be really upfront about your family members, how you maybe dealt with certain things, mistakes that you made, right? Aspects where you actually had your own stigma, and then thinking, oh my gosh, I recognize that happened. And kind of owning that it opens the door so that other people feel like it's okay to talk very openly about it. And we're all going to make mistakes in these kinds of situations, and that's also fine. Recognizing that everybody sort of brings a little bit of stigma to the table, and then if we can see it, then we can do something about it. So,
So true.
that's been really helpful for me, I think.
Yeah, so true. Fantastic. My friend was thinking about overdosing. They are seeing a therapist now, and I still ask if they're suicidal. And they often say not anymore. What else can I do?
Good for you for asking.
Yeah.
I mean, thank you for doing that. Exactly.
And for continuing to ask.
Whether you did it while looking in the mirror first and
Yes.
practicing or not, I mean, and I think, from any type of place of crisis and when you're de-escalating, there's no perfect way to go about that. But, anyone who's done any type of intervention, and this is what you did an intervention, you talked to them. You don't need to keep asking every day. You can start to space it out. And I think, that idea of a check-in later on is not a bad idea. You're not going to make them suicidal, as Rachael mentioned, but you can make someone annoyed if you ask them every hour on the hour after they were last suicidal about a month ago. So it's a balance, and I think just even wanting to know how to proceed. That's the goal for this kind of community engagement. It's saying I'm here and I want to do as well as I can, and so reaching out for help to kind of see the pacing. But the other person who can tell you how often to ask might be your friend who is suicidal, and you can have a conversation. I still worry about you. I'm owning that, but you're telling me you're fine. Like, when do you think it'd be okay for me to check in with you again? Because they probably have a pretty good idea.
What I'm hearing from this person and their question is they're just the seeds of recovery
Yeah.
are there, and
Yeah.
people do recover
Yes.
from suicidal crises.
Yeah. And you've created a safe space. You've created, they know that you're somebody who they can come to, which is really important. And as I was talking earlier, pay attention to warning signs. If you see that friend start to behave differently or engage in some other warning signs, then that may be an opportunity to say, to bring it up again. So I love what you said, Brooks, about sort of ask them, right? So many times when people are really struggling with suicide, they feel out of control of their lives. They don't feel like they have a whole lot of autonomy or decision-making ability. And when you can involve them in that and give them some power in that, it can really make a big difference.
And it's also important just to make it feel normal, right?
Yeah.
So sometimes if you're with somebody who's really struggling, you feel like you have to be careful with them, that there's certain things that maybe you shouldn't do. And that you can't really, approach certain topics or something like that. And I think being really open about that with people and saying, hey, is this okay? Can we do this thing? And just trying to make your interactions feel really supportive, but also just normal. And that talking about this then becomes normal and fine.
And I want to sort of also wrap something into this, and that is what do I do if they say they are? And one of the things I said before was listen, obviously, listen. So incredibly valuable. But one of the ways that you can feel better prepared to have a conversation about suicide is to know what your resources are. Mm-hmm. Know that if there is a critical issue going on, what am I going to do? Michael mentioned this earlier, 988 is now the National Suicide Prevention Lifeline. It is across the country, 988, and if you don't want to call it, you can. There is a Lifeline Chat. Reach out to those individuals. That is always an option, and say to them, it sounds like we may need to talk to somebody. Let's call 988. Do you want to do it from your phone or my phone? Give them some autonomy, give them some power in that. You know what, I'm really worried about you and I'd like to take you to the emergency room to get some help. Are you willing to come with me? Give them some power over their lives, but recognize that there are things to do. When somebody walks in, demonstrating signs of a stroke or cardiac arrest, we know what to do. We've been trained over and over and over what to do, and so our brains just sort of kick into an automatic response, right? And so knowing that there is something within your power, within your capacity to do when somebody says yes, I think is really, really important.
Yeah.
Mm-hmm.
Finally, with our just last couple minutes, as somebody who has attempted suicide myself and who has visible markers on my body, how do I explain this to people? I have a hard time getting over the embarrassment.
First of all, you don't owe anybody anything.
Right.
So if you don't want to explain whatever is visible on your body, then just don't. I think the best learning moment that I had was I asked somebody about their tattoos, and tattoos are personal, and some people like talking about them and some people don't. And if you're not ready to talk about whatever signs are on your body, then the best thing you can do is just say, that's private, and you don't have to.
Yeah, it's like any medical condition, right? So if you had a scar from a surgery, you have a scar from a surgery. I mean, you can assume that this is part of your past medical adventures in your life, and we all have them. And again, yeah, just like Michael said, it's like, okay, this was a medical adventure, and you're past it, and yeah, you don't owe anybody any explanation.
Yeah.
And I think, in terms of, it sounds like at the point where you're at right now, you're at a stage within your recovery, and recovery is a process. It's not a goal. It's a process that we go through, and sometimes there are harder parts than others. But there might come a time when your experiences and your knowledge can be helpful to someone else. And so I think thinking about where you are and where you are in that process, there might be someone who will benefit from knowing about your experience. And that's not something that's really easy to do on the fly. I mean, I think it takes thought. I think it takes, if you've got a support system, professional or family or social or otherwise, I think it's something to think about and to get feedback on. But some of the folks that I've learned the most from are survivors. And so I just want to make sure that you hear from us that, when you are at a position where you are able to do that for someone, there are lots of folks who can benefit from learning about your experience. And however, whether it comes out through something that is visible on the skin or just you sharing it, but it gets back to that original point around how do we reduce stigma, how do we make this part of our culture, that we're open and we're able to talk about it, and how do we learn from the people who are best positioned to teach us, and oftentimes those are folks with that lived experience.
Oh, great answers. And we're just about at time. I want to thank the panel members. You guys brought some really powerful and valuable information to the community, and I think that we covered a lot of really good topics. Do you have any sort of final thoughts that you wanted to share, or do you feel like you covered what you wanted to?
I'd say take a training. There's lots of trainings.
Oh,
QPR, mental health first aid.
Yep.
I think Human Services is doing an assist training. That's a more engaged training on how to respond adequately to a suicidal crisis. Put 988 in your phone. If you're in the National Guard or attending any school or university, make sure Safe UT is on your phone. Even if you're not suicidal, you might have a friend who is, and you're ready to go.
Yeah. Thank you so much, and thank you everybody for attending today.